Thank you very much.
Yes, thank you. Thank you so much for your kind invitation. I was very happy to come here in Belfast, my first time. I will speak about dosimetry related, of course, of radiopharmaceutical therapy, not dosimetry in general. And in particular, what the nuclear medicine physician like me understand about that. So I will say something about facts, dosimetry aspect, in theory and practice, and then some conclusion. I have absolutely no conflict of interest in this setting. So the facts are, first of all, I think that theranostic and precision medicine are the future of nuclear medicine, at least the oncology, nuclear medicine in oncology. And in order to ensure that we administer the right patient, the right drug, at the right time and at the right dose, I think that dosimetry is really fundamental. Moreover, we know that there is a clear dose-related efficacy of the injected product, and that the legislation implies that, requires that we have to optimize the radiotherapy, including nuclear medicine therapy, with dosimetry, and this has been also endorsed by IEA. However, in order to have a comprehensive understanding of the principle of radiopharmaceutical therapy and dosimetric calculation, I think that we also have to understand the fundamental of theranostic in nuclear medicine. So I would like to start with really basic. What is, in my opinion, radiopharmaceutical treatment? So we can look the radiopharmaceutical treatment as a target radiotherapy. Indeed, we use ionizing radiation to alter DNA, and the goal is to have the maximum irradiation of tumor cells and the minimum toxicity on the health cells. For this, we can use the radiotherapy paradigm, that is the amount of radiation energy absorbed per unit mass of tissue, that is the gray. However, we can also consider radiopharmaceutical therapy as a radiation antineoplastic treatment. We have a method that is tumor-specific, because the radiopharmaceuticals are specific to a target, an oncology target. We can administer it systematically, eventually also locally. And the goal is to have the specific action on the primary tumor and also on its metastasis, if it's systematically administered. So for this, we can imagine to use chemotherapy paradigm, like the amount of drug per mass of body weight. And that's why sometimes, and I think it's completely wrong, but sometimes we use still in nuclear medicine, we give a dose of 100 millicuries, for instance. In my opinion, radiopharmaceutical treatment is a unique modality that is adaptable to a particular cancer and to an individual patient. That's why personalized medicine. And the idea is that we don't have, in my opinion, radiopharmaceutical treatment paradigm still. Now, what is the role of dosimetry in this treatment? We have a radiopharmaceutical, we know the activity, we know the target, and by the biodistribution, we will calculate the dose, and we will relate the dose to the effect. That could be either a toxic effect for the side effect, or what we want, that is the anti-tumor effect. This is rather easy, but the situation is a little bit more complicated because we have the administrative activity and we have the target. From the administrative activity, we can go to imaging, of course, rather easily, from radiosensitivity of the tissue, we have the target and the toxicity. The first problem is when we go from biodistribution and imaging to dosimetric methods that are models, of course, and these models should represent the absorbed dose. And the absorbed dose goes to the tissue. The other aspect is that the efficacy is related to, of course, to the target, but we don't precise if it's experimental or it's in clinical aspect. The efficacy can be palliative, curative, or adjuvant, and the impact is on overall survival or on progression-free survival. So this is something to define. Then, in order to consider the toxicity, we have also to consider the radiosensitivity of the tissue and the dose-limiting organ. We will see later on why it's so important. And there is something that is missing, and I think that is fundamental in this aspect, is the dose rate. We have absolutely no clear idea of what the dose rate will impact on the absorbed dose. Indeed, if we look at dosimetry in external beam radiotherapy and radiopharmaceutical therapy, there is a big difference. In external beam radiotherapy, clearly, it's easy to calculate the dose to the target, because from the beginning, we know what is the amount of energy to be given. In nuclear medicine, it's much more complicated, and there are several confounding factors. The first is the dose rate, and the second is the errors in measurement. That is mainly true for systemic treatment. So the dose rate clearly is not the same if we use the external beam radiotherapy, that is like a thunderbolt, or a radiopharmaceutical therapy that is given in days or even weeks. And I have the impression that the gray of external beam radiotherapy is not exactly the same as the gray of radiopharmaceutical therapy. Like these are two grays, the same man in two different age. I have the impression it's not exactly the same. And this exists in literature. We have a paper speaking about wrong extrapolation from external beam radiotherapy. And this is why the dose-limiting organs are normally, as far as I know, evaluated from external beam radiotherapy. And I don't know if this is correct. And another recent article published in GNM. There is also something clear in external beam radiotherapy, even they know, when they do hyper or hypofractionating, that they may have similar effects, but different total dose. So this is, if the dose is fractionated, they have these aspects. Now we move to the measurement, and first of all, imaging parameters. Of course, the best case is radioiodine, when you have iodine 124 and iodine 123, and for therapy 131. But still, I think that there are some differences, and sometimes we can find, because of the activity is higher, of course, we can find some unexpected localization with diagnostic and treatment aspect. This, of course, I'm speaking, I'm sorry, I jumped this explanation. I'm speaking about the pre-treatment dosimetry, of course. And if we look at other theranostic agents, they are unpaired. For instance, for prostate cancer and NETs, we use gallium or technetium for the diagnosis, and lutetium or yttrium for therapy. For the radioimmunotherapy, we have the antibodies that have completely different aspect if we are labeling with one or another radioisotope. And the most difficult, of course, is target alpha therapy, where I think there is no real model that can be used in diagnosis. We have another aspect that should be considered, is the tissue heterogeneity. The microdosimetry is using Monte Carlo system. I think that my friend Glenn Flax tried to explain me once what was Monte Carlo, and I didn't understand very much. I understand that it was, of course, related to statistics, and so maybe not really, it's a model and not the reality. The tumor has a variable uptake. We have peak of high tumor uptake, but also normal uptake within the tumor. And this is true also for normal tissue, where the uptake can be very heterogeneous. Therefore, also, when we consider the toxicity on non-target organs, we have to consider this aspect. Then we have also what is evident is mistakes in calculation. And I cited here two, I think, very nice articles from physicists claiming that there is clearly some variation in using one on the other calculation model. And this is the general theory, and you see that in italic there are the uncertainties in the principal quantity that needs to be known when estimating the mean absorbed dose. So in summary, there are errors in dosimetric calculation related to measurement or also to other aspects like individual variability in DNA repair or extremely long dose rate. The clinical consequence of this is what happened now, is that unfortunately, there is no randomized phase 3 trial with adequate methodology, and the reason is not scientific, because there is a big scientific interest, I think, in this. The reason is economic, because nobody would afford the cost of this with maybe a result that is not the one that is attended, that dosimetry is fundamental. This is what I think, however. The fact is that there is actually no clinical evidence for dosimetry, and there is, and this is also a more important aspect, an imbalance between the accuracy and the complexity of the procedure. Therefore, unfortunately, empirical fixed activity is judged as clinically sufficient. And this is the example of the thyroid cancer. It's called magic bullet, and what we call magic means that we don't understand. This is obviously, no? So I'm finishing with what is the present. In present, we have the choice as nuclear medicine physician of not doing dosimetry. Of course, the advantage is you no need for planning simulation. It's much more simple. The disadvantage is you don't give a tailored treatment. We have unpredictable toxicity and not optimized dose. If we do whole body dosimetry, it's a good estimation of non-target doses, the toxicity. It's good clinical practice and it's followed the legislation. However, we have several logistic problems, minor. And if we do tumor dosimetry, the advantage is really you have the desired tumor effective dose. The problem is feasibility and low accuracy. But I hope in the future, and one thing that we have seen those days is, for instance, the total body PET. So what I said about the measurement, what I said about the problem of unpaired isotopes can be maybe solved. So I'm really optimistic in the future. Sorry, see, for the moment, this tumor dosimetry is essentially in radiopharmaceutical development, so in preclinical phase is used, unfortunately. So in the future, I think that the nuclear medicine scientific community, so physicists and physicians, must endeavor to develop a reliable and feasible dosimetric methodology. I think it's feasible, but not for the moment, within current practice. The effort is crucial to ensure that the right drug at the right time and the right dose is administered to the right patient. Thank you very much for your attention. This is a picture I get from.
Thank you very much, Francesco.